Sir has done Sir has done his BMS from Mysore University and MD from Banaras Hindu University in 1983. Sir has got a vast teaching experience from 1983 to 2018. Sir is HOD of Department of Shalyatantra, SDM, College of Ayurveda, Kuchipudi, Udupi. And Sir is Professor Emeritus. And Sir is a very good clinician who holds the patients very patiently and he treats the most critical cases in his life. And Sir is a really an inspiration and he is teaching in a very beautiful way with the basics how to use the medicines, in which conditions to use, starting from the simple diseases to the critical disease. So here we are today solving the mysteries of autoimmune disorders, which is syndrome-like presentations affecting most of the organs of the body, and the life of the patient becomes crippled. To save the patient from that situation, Dr. Muralidhar sir is there for guiding us. Sir, we welcome you.
Okay, thank you. I, if I am allowed to share the screen, I think.
Yes.
Yes.
I hope the screen is visible, no?
Yes,
Yes,
sir.
sir.
Okay.
It's quite visible.
Right. Thank you for giving me an opportunity to be with you. Now I'm supposed to talk about autoimmune disorders with a clinical outlook of Ayurveda. Now, a bit about what is autoimmune disorder. A history of the autoimmune disorder in the Western medicine. Probably pathologists might have spoken a bit more about that, but I'm just looking commenting on these issues from the point of view of from Ayurvedic point of view, like how it could be stabilized. Now, history of autoimmune disorder is very short. Right, the idea of an autoimmunity in Western medicine was only in 19th century when Paul Ehrlich coined the word as autotoxicus. But real concepts of the autoimmune disorder were developed by Neil Rose, who is supposed to be considered as the father of autoimmunity, and this has developed only since 1957. So it just 1 year older than me. The whole history of autoimmune disorder is just 1 year older than me. In the sense, it was started in 1957 and I was born in 1958. And the list of autoimmune disorder is growing very rapidly. So initially, that idea of autoimmunity was limited to very few of the conditions. Now it's getting added, and there is a global autoimmune institute which is just keeping count of these autoimmune disorders. And those who are interested, they may go into this reference site like the URL, and then there you have the updated list of autoimmune disorders in the form of A to Z fashion, and almost every disease now is getting included. Many of those diseases which were not in the domain of autoimmunity earlier, now they have become autoimmune disorders from that point of view. And the current count is around 96, and it is expected to reach 120 within a short period. Now, how to confirm whether a disease is autoimmune or not? There is a criteria to confirm autoimmune disease identity, and that criteria is established in 1957. That's why I said the whole history of autoimmune disorders starts from 1957, and it's based on Wittgenstein's postulates by Ernest Wittgenstein, and the three important postulates are: one is the direct evidence from transfer of the disease causing antibody or disease causing T lymphocytes in white blood cells. So about that investigations and then identification of the abnormal cells, probably they might have been discussed earlier. Then indirect evidence based on reproduction of the autoimmune disease in experimental animals. The third and most important criteria is the circumstantial evidence from the clinical clues, and those circumstantial evidences which are listed as the standard clinical signs when you have to suspect about the autoimmune disorders are those diseases which present with fatigue, joint pain and swelling, skin problems, abdominal pain or digestive issues, recurring fever, swollen glands. These are considered as the clinical signs of autoimmune disorder. Once the autoimmune disorder has been established, then the course of the autoimmune disorder in general follows a specific pathway that initially, see, there are two important issues. There is a genetic predisposition. Genetic predisposition could be there due to since birth, or certain of the genes also are identified which predispose the person to autoimmune disorders. But there is always a triggering factor. Unless there is a triggering factor, till that triggering factor is there, the whole disease will be subclinical or it will not be presented at all. Once there is a triggering factor, which is usually the triggering factors, I'll come to that part, it results in a changes in the environment of the the immune conditions, and it results in cytokine production, and the cytokine production again spreads in the form of epitome spreading, and that results in the later consequence like damage to the cell, or it could be a resolution as such. Now, there is a lot of new research areas going on in the related to the triggering factors. See, there are two important issues. One is about the genetic factor, and the other is about the triggering factors. Genetic factors, of course, it may not be easy to change, but the triggering factors for the autoimmunity is another major area where either you can prevent or maybe you may have something which can be considered as a cure. Now, among those identified triggering factors, and the major amount of the research going on are in the area of microorganisms. Infections can trigger the autoimmune disorders. Sunlight associated with autoimmune disorders. Childhood poverty linked to rheumatoid arthritis in adulthood. Agricultural chemicals and rheumatoid arthritis. Organic mercury may trigger autoimmune disorders. Role of nutrition in development of autoimmune disorders. These are the certain green areas where the researches are going on in a huge amount. But the maximum number of articles which are coming up now, there is a floodgate of rather research articles. If you look at the research activity throughout in the internet with having some base standard research articles, you will have plenty of research articles where the gut health and autoimmunity are related to. There are, again, to go into all that would be quite difficult. I have those who are interested, they may go through these references, the articles which are of very significant importance, like which are rather game-changing articles, where the perception of the autoimmune disorder is directly related to the health of the gut and diet, food, and so on. Now, there are different views. I will not be going to that part, like the details of these. But if at all I have to summarize, what are those outcomes of those different sorts of the research approaches to the gut health is, ultimately, if you have a discipline in consumption of the food, and if the food is not allowed to be a toxic substance, see, there could be a toxic substance, either it could be the nature of the food, or a toxicity could be generated within the body, which could be resulting in the diseases like and that perception of that toxicity also has changed a lot from at different time intervals. Like initially it was considered as antioxidants, and then you have the residual products and so on. So lots of the issues are there. It's not my point, but the point is, if at all you have to summarize in a single sentence, I would be saying that the best of the summary of all that research activity would be what Sushma has said as Naram Parimitaha Labante Vitravaha Murahatan Vitra Ajitatmanaha Labante Kalushashayaha. So if you have a discipline of the food and if the gut health is maintained, chances of having an autoimmune disorder is significantly lesser, even if you have a genetic predisposition. That's the important point, and that's the most relevant issue, and probably this would be the future about the autoimmune disorder as such. Now, whatever that detailed researchers activities and that 5 molecules and hundreds of names is not important. Now, the idea of a gut condition resulting in toxic consequences is not new to Ayurveda. It's originally from Ayurvedic point of view that we have the idea of all the diseases being related to the food and the radiation. When Taraka says like the ajirna, which could be produced due to the plenty of causes like abhojanat, ajirnat, अतिभोजनात् विषमाशनात् असात्म्य गुरुशीत अतिवृक्ष संदुष्ट भोजनात् विवेक मनस्नेह विभ्रमात् व्याधिकर्षणात् देश काल ऋतु वैषम्यात् वेगानांति विधारणात् the different triggering factors which can result in दुष्यति अग्निः सदुष्टो अन्नं न तत्पचति लभति अपच्यमानं शुक्तत्वं यात्यन्नं विषरूपतां the anna the food itself becomes a visha which can damage the tissue. This is the original idea of a endogenous toxicity which can produce the damage to the tissues. Now, if the food is not provided properly, when Bhagavad says, like ahara madni pachati, pachati doshan ahara varjitah, dhatum kshineshu dosheshu jitam dhatu sankhay. Now, if the food, proper food, now it's not only, many times it is, this sloka is translated in the form of effect of starvation. It's not effect of starvation alone, it's effect of having improper food. If the food is not proper and the food is not digested, the whole digestive process can result in damage to the tissues. It can result in the dhatu paka. Dhatu paka is the original idea of Ayurveda, which is absolutely the same as that of what we call as the autoimmunity. Of course, the धातु पाक can result in sammadhyamanah shriti napiseshu gatreshu pakarujanmiteshu. It can produce the lesions anywhere in the body. It could be in the core part of the body, shriti napisesha, or it could be in the periphery. Pakveshu ateshu jatah sadhatvaki kachito vishabhi. Now, the same ama, the other way, the same is translated as ama. And ama again, word often is interpreted in different manner. Now, Bhagavata gives that interpretation of Ushno Alpabalapena Dhatum Adyam Apachitam Dushtam Amashekritam Rasam Amum Pratekshade. But more important would be Anye Doshebhya Eva Atidushtebhya Anyanyam Murthanad Kodravebhyo Vishatseva Vadanti Amasisambhavam. A Kodravebhyo Vishatseva, where the normal reaction, instead of the normal fermenting reaction, a toxic substance is produced. Similarly, in the body, the normal synchronous activity of different molecules, chemical activities, when it has lost the track and has produced some abnormal condition, that itself can result in the ama. And when Ayurveda says that every disease has a linkage with the ama, and hence the disease is called as amaya. So, and sarve rogaah mandeno. As long as you have the Agni as a normal property or normal functioning, you will not have a disease. These kinds of the concepts are exactly the same concepts which are now being developed or which are being investigated or rather presented as new research activities. And gut health and the disease conditions. Gut health is now, there are two important areas in the modern science developing. One is the linkage of the gut to the brain, gut-brain axis, one, and other is gut and the immunity. These are the two important areas. Now, if you have that brain activity and immune activity, that's a complete thing. Like almost every disease has a consequence of that. Now, once this process has occurred, has started, it can result in kramena upachayam prapya dhatun anugatashyanehi nashakyaha unmulayitum ruddho vrikshayvamyaha saha stiratvat mahatvacha dhatu anukramana ja. The dhatu anukramana. So once the disease has occurred and it has involved the tissues, then that tissue will be producing more and more diseased tissue. There is a sequential propagation of that diseased tissue, and hence the usual medicines would not activate that. Now, once that ajirna or this ama has occurred, it can get accumulated anywhere in the body and can produce the different diseases, and those diseases are exactly either it could be now but you are able to see on the screen is about the different locations where the autoimmune disorders can present in the different organs of the body, and that's exactly what the Samhita says, like Either it could be over the gastrointestinal tract, simple, arochakaha vipakasya ghoram manvisham tata. Samsajyamanam pitteha daham tushnam mukhamaya. It could be mukhamaya or amla pitta in the abdomen, or it could be yakshma pinasameha, systemic infections conditions, or karoti vata system, vata jamsha. Due to the involvement of vata, it could be lesions in anywhere in the body, like vata, etc. Or mutrarogamsha, urinary system, or kukshirogan, shakradgadam. These are the different locations where the disease could be presented as a result of this ajirna or dahana. Now, if you look at the whole concept, that spectrum of autoimmune disorders in the current situation, it's exactly the same. Only the thing is the language is different, the details are more, and this is exactly like either it's a reinventing the wheel or whether the wheel is remodeled. So concept of autoimmunity is not new to Ayurveda. It's not only 64 years old, it's 5,000 years old. And you have a well-defined strategy for that. Now that's about with history. Now let me directly jump into the current issues and the treatment from the management point of view, or the clinical experience of the autoimmune disorders. Now, as per the available data, from the source of this, you have a very typical distribution of the autoimmune disorders. Incidence of the autoimmune disorders are comparatively lower in India as per this data available. Now, whether this low incidence is a real reflection or whether this low incidence is due to a relatively poor infrastructure for the diagnosis, whereas the incidence of these autoimmune disorders are more in relatively developed countries, this distribution. Now, very comparatively, if you look at the worm infestation, the helminths infestation, the incidence, there is a very significant contrast in the distribution of the worm infestation and the autoimmune disorders. I don't say that worm infestation protects you from the autoimmune disorder, but the worm infestation could be in the gastrointestinal tract, could be one of the localized consequence of the indigestion or improper agni function, which may prevent it from becoming a toxic pathology, whereas autoimmune disorders is the other way, where the toxic substances are absorbed. So there is a sort of distribution which is not easily explainable, but there is a very significant contrast in the incidence of worm infestation and incidence of the autoimmune disorders globally. Now, pattern, the spectrum of autoimmune disorders. If you look at the data from the Western countries, maximum number of autoimmune disorders are related to the thyroid. Psoriasis comes next, rheumatoid arthritis comes next, and the others, the type 1 diabetes mellitus, and so on. All that numbers, different diseases, their number, the distribution pattern is like that. Whereas thyroiditis is more common. Whereas if you look at the statistics of what we see in India, the spectrum of autoimmune disorders in India, significant 39% of the autoimmune disorders diagnosed in India are rheumatoid arthritis conditions. Then the other varieties. Now, this kind of a difference is also significant from the clinical point of view, because you will see more cases of rheumatoid arthritis. Whereas if you look at the textbooks, you will find more detail about autoimmune thyroiditis than the other way. Comparatively, autoimmune thyroiditis seen in our country or in among the patients whom we see would be comparatively lesser, whereas I'll come to that part. The thyroid diseases which we see are of a different category, not that of the autoimmune disorder. So many times following that Western textbook often may give you a sort of different sort of the perception. The cause for this now distribution could be, that variation in the distribution could be either the genetic predisposition is not yet known, or it could also be a consequence of the infrastructure related to the investigations. Investigations related to the autoimmune disorders are rather very complicated, rather very difficult, rather, and the facilities, infrastructure for that is not so easily available in our country, not as in case of the Western countries. Probably about the investigations, we might have had that discussion yesterday, and all that identification of the T lymphocyte series, and then these antibodies, identification of the antibodies, it requires more sophisticated setup, which may not be so easily available to the middle class patients in relatively semi-urban and the rural areas. Maybe in the metro cities, that facility may be comparable to the Western countries. But when it comes to the question of statistics, that it will be having an impact on the area where the patients will be more, and that's in the semi-urban and the rural countries. And the whole infrastructure is gradually developing in India throughout the globe. That investigational facilities is increasing very rapidly, and the market of the increasing these investigational facilities is one of the major areas of the finance related to the pharmacy asset. Now, though it's not my domain, I think there is a need to just casually mention about the approach to the autoimmune disorder. Once the autoimmune disorders were established and then a approach to the treatment was started, rather a successful treatment was after the glucocorticoids being used. Glucocorticoid was rather glucocorticoids were really being used in significant quantities, and with all that maybe evidence-based approach of significant was shown in from the period of 1950 to 1960. These are considered as the golden area where glucocorticoids were considered to be the ultimate choice, and that has produced a very significant change, and almost it was considered like every autoimmune disorder could be treated with the steroids only. But gradually there was more and more of the rather alternative approaches coming through, and that alternative approaches like target oriented drugs, they have come. And moreover, in 2017 there was a rather U-turn, that glucocorticoid toxicity was established, rather it was publicized, and the total approach was now changed. So glucocorticoids now are not the primary drugs in the treatment of autoimmune conditions, but rather you will have the targeted drugs, DAGR drugs like tocilizumab or tocilizumab, so on, those which are prohibitively costly drugs. Now, in the trends in the management also is changing, like, and as I said, again, this is not a very important issue from our side, but the important is contemporary medicine, in the Western medicine, the trend is changing very rapidly. In 1975, gold alkaloids were and sulfasalazine was considered as a priority drug, whereas now it's the small molecule drugs like tocilizumab, which is the drug of choice. So the whole approach is changing very rapidly. Prescription patterns are changing rapidly, but still the outcome is not very clear. Anyway, it's not my important job to go into that part. Now, coming to the diseases which we consider as the autoimmune disorder, I'll directly jump into the clinical approach with the rheumatoid arthritis. Rheumatoid arthritis, ICD international code is a M86.9. Of course, autoimmune disorders are not yet classified as a separate entity in the ICD international code. There is a discussion, and probably in the next revision of the ICD, you may have an appendix chapter and a appendix code, separate code for the autoimmune disorder. Now they are coded as per the routine systemic pattern. Now, rheumatoid arthritis, as per our text, the description is exactly that of what we call as the Amavata, where the clinical description would be Angamartaha, Arujihi, Trishna, Alasyam, Garom, Joraha, Apaka Shunatangana, Amavata selection. सकष्टः सर्वरोगाणां सदया प्रकृतो भवेत् हस्तपादशिरो गुल्फत्रिकजानो वृसन्दिशो करोति सर्वजं शोथं यत्र दोषः प्रबध्यते सदेशः रुच्यते अत्यर्थं व्याविद्ध इव वृश्चिकैः. So the vitiated contents reaching to any of the areas that can produce the involvement, and it can present with the clinical presentations of the arthritis. Now, I have taken up rheumatoid arthritis as the first condition related to the autoimmune disorder because that's the one which we see in the large number, and that's where we can really make a significant change. Ayurvedic treatment can produce a significant change, and from that point of view, I have started discussing about the rheumatoid arthritis in the beginning, then really going into the other varieties. Whereas if you see the Western textbooks, probably thyroiditis is discussed first and then the other diseases. So that sequence we will change according to our clinical view. Now, of course, these are all the primary issues. The typical criteria for making the diagnosis of rheumatoid arthritis, as we use now, the clinical criteria would be, I think this is something which everyone knows, every graduate will know, like morning stiffness, arthritis of 3 or more joints, arthritis of hand joints, symmetric arthritis, rheumatoid nodules, and serum rheumatoid factors, radiographic changes, etc. I think I will not spend more time on those basics which you have already known. But before we plan the treatment, we need to predict about the outcome. And to predict the outcome, you need to assess the severity of the disease and then, of course, grade that course of the disease. Now, grading of the disease could be in the advanced stages where there is a radiological changes. A standard protocol is the Lassell method, where the number of joints involved, they could be counted, and you will have a typical scoring, and based upon the scoring you can have that grade 0 to grade 5 changes produced in these individual joints seen on radiological, and then counted over there can give you a scoring of that. But a better and a relatively easier, where you do not have to go for the radiological changes and not much of a difficulty, is the latest, the 2020 Euler classification of rheumatoid arthritis. This is somewhat more useful, easy for the clinical approach. And the involvement is, if there is a single large joint, the score is 0, 2 to 10 large joints, 1, whereas more than 10 joints, at least one small joint, the score would be 5. Similarly, serological tests like negative factors or ACCP investigations will give you that score of 0 to 3, and reactions, acute phase reactions like CRP or ESR, they, where again you will have 0 to 1 score. Duration is again less than 6 weeks and more than 6 weeks, you will have the scoring, and this scoring would help you to grade the condition and predict the outcome. Higher the grade, so it's important in this titer level of RA factor or titer level of ACCP and is not a criteria to predict the outcome. It can predict about the course of the disease. Higher the titer value, the patient may have more severe symptoms, but many times such patients respond well to the treatment, whereas those patients who may have a lower level, they may become difficult to the treatment. Rather, outcome can be predicted better by the grading of overall pictures, like, and it's not the reading of RA factor. Now, that should be before you make a diagnosis of rheumatoid arthritis. It's also important that you need to rule out the conditions like psoriatic or viral arthritis, gout, etc. And then only we will make this. Now, ultimately, the grading would be, if there are no clinical signs like tenderness or edema around the joint, then make it as a grading 1. If the joint has a soft tissue swelling, slight joint space involving narrowing, like, then it's grade 1. When there is a definite early abnormality and 1 or 7 erosion seen in the X-ray, that's grade 2. And when there is a severe destructive abnormality, marked erosion seen in the X-ray, grade 3. And severe abnormality with the large erosions, grade 4. Gross deformity, the bony outlines of the joint have disappeared. Now, in this condition, when I approach the treatment from my Ayurvedic point of view, I would consider the patient as Amavata, but in Amavata, my categorization and my grading would be based upon the dosha lakshanas. Ultimately, it's from Ayurvedic treatment point of view, it is the dosha lakshana which is the most relevant issue than really the other criteria. Other criteria of investigations, they are absolutely necessary to predict the outcome and be relevant, but at the same time, when you select the drugs and then manage, you need to have a doshic approach. And from that point of view, usually grade 1 up to grade 1 to grade 2, I would be considering this as a Pittaja Vyadhi, Pittat Sudaharagam, and if it's a but the inflammation is but somewhat more severe and there is an edema around Sashulam Pavananugam, it's a Vataja Vyadhi, and when there is a lot of erosion and the bone has become destroyed, then it's a the Kafadushtam ja Pitat Sadaharagam, Sashulam Pavananugam, Stimitam Gurukandum ja Kafadushtam Tamadisheta. This is one way. At the same time, when there is a very gross deformity and there is a possibility of systemic involvement, that becomes a Didoshaja or Tridoshaja, Ekadakshanugasadhya, Didosha Yapi Uchete, Sarvadeha Charaha Shotaha, Sakrichaha. Now, my prescription would be again based upon the dosha lakshanas only, and the dosha lakshana would be in the pittaja, that's in the initial stages. Usually the course history would be 6 months to 1 year, and the joints involved are comparatively lesser, and the local signs of inflammation are very prominent. Edema is there, extracellular edema is there, reddish color is seen, not much of a deformity. My prescription would be Kaishora, Mrityunjaya, Amritarishta, and Dashamula Nirohavasti alone. In case of the grade 3 to 5, where the deformities are more, duration is longer, then my prescription would be Gokshirati, Mrityunjaya, Punarna, Amandura, Amritarishta, plus Agni Chikitsa and Ksharabasti. Agni Chikitsa is a specific form of application treatment, Pachana Chikitsa, used in SPM hospital, and that's my preference. And majority of the patients who come to us, they will be coming in this category than in the earlier category. That first category patients are comparatively lesser. More of the patients are in this category where Vata predominant Amavata is seen. Results are in these early stages, the results are good, whereas in the other stages, definitely we can have a better palliative treatment. Patient can have a better quality of life, and compared to the contemporary system, definitely our outcome could be better, and the patients will be accept this. Rather, you will have more patients accepting this treatment than the other way, contemporary treatment, irrespective of the type of the contemporary treatment. It's not made up to comment on that part. Whereas when the patient has a very gross deformity and significant radiological changes, where Dhatuksha Lakshanas also are presented along with the Kapha Lakshana, maybe it could be Dandaja or Tridoshaja or Kaphaja. In that condition, the outcome would be poor. And once there is a gross deformity, it cannot be changed completely. And in that condition, my approach to the treatment would be preference would be, my prescription would be Gokshurati Chandraprabha Shogandharishta Agni Chikitsa Ksharavasi alternated with the Virechana. Virechana only in that condition. Now, when I say that these are my drugs which I prescribe, that doesn't mean that these are the final. It's only about identification of the category. The point is that dosha lakshana is the most critical method of planning about the treatment. You may select any of the other drugs based upon the dosha lakshana. That's not the important thing. So it's not that these drugs are final. You may select any of the other drugs which are available. In rheumatoid arthritis, the other important issues, many times patients of rheumatoid arthritis will present with the very frequent complications, and well-established complications of the rheumatoid arthritis are stroke, eye problems, lung problems, diabetes. I have just summarized it without going into detail. Psychological conditions like depression and anxiety, heart diseases, vasculitis, blood diseases, where you will have blood dyscrasias, osteoporosis. Now, in these conditions, you may have to have additional approach to the treatment. Incidence of the stroke after rheumatoid arthritis is not a very frequent event, it's rare. And whenever you have such a patient, my approach is a Pakshagata regime, the same Pakshagata regime which I use for others, depending upon the dosha lakshanas. And I will not go into that detail now. Patients with the eye problems, the best there will be scleritis, irritation in the conjunctiva and infiltration in the conjunctiva, and Dhanya Kahima is a better option of additional treatment in addition to that basic line of the treatment which I have discussed. And lung problems, incidence of this fibrosis in the lungs and expectoration or many times bronchiectasis-like features can occur in patients of rheumatoid arthritis significantly, and in that condition, my preference would be Makarabda Lagusudha Mishana, considering this as the Kshayaja Kasa. Kshayaja Kasa is the idea perception of the lung diseases in case of rheumatoid pathology. It's Dhatu Kshayajanya Kasa or Amavishajanya Kasa. Then diabetes is of course another of the common problem. There the treatment is there is no other specific treatment. All the prameha result as we follow the prameha conditions. Patients with the psychological conditions, very common. In case of rheumatoid arthritis, this is very common because of the chronicity of the disease or many times a indirect consequence of the disease. Patients may have psychological issues, and in that condition, my preference would be Smith-Sagar, Saraswati, etc. Cardiac pathologies, compared to rheumatic, incidence of cardiac pathology in rheumatoid is comparatively lesser, but still it can occur. There, one of my prescription with Bhakaravati, but I don't say that every patient can manage it only with our drugs. Many times you may require a cardiological reference and certain other cardiological supports may be required. Vasculitis is another frequently occurring complication of rheumatoid pathology. I would be considering this as the Rakta Prakopa, and the treatment, my prescription would be Kamadukha Manjastadi Ksharabasti. Manjastadi Ksharabasti is the other treatment. Vascular disorders like either it could be anemia or cell count being altered, blood dyscrasias of different sort, depending upon the clinical presentation, either it could be Arogyavardhini or Punarna, the additional drugs which I prescribe. Osteoporosis, Chandraprabha and Yapanavastis are the other way. So that gives in brief about the gamut or the scheme of treating rheumatoid arthritis in my clinical practice. Now that's one. The next of the disease, again frequent autoimmune disease, which we see quite frequently is SLE or systemic lupus erythematosus. Rheumatoid, SLE, these are the conditions which are rather the bread and butter of Ayurvedic practice. Majority of the patients, they end up in Ayurvedic clinic. So from that point of view, I will just refer to these issues. Again, I'll repeat that when I say about these diseases, it's not about the classical textbook presentation. It's about what we see clinically. Now, incidence of rheumatoid SLE is also comparatively lesser in India compared to the other Western countries. So, India is comparatively the incidence is lower, where I think you can make out that. And from the clinical point of view, it's a enigma condition. Disease which can present with different sorts of the presentation, and the whole gamut of the presentation of rheumatoid arthritis itself, SLE itself is very difficult or very complex, and hence many times the clinical diagnosis becomes difficult. In maybe to a certain extent, we can classify these diseases or presentations into the neurological presentations, which is around 18%. Serositis, where the patient may have involvement of lungs or heart conditions, it's around 19%. Then the blood dyscrasias, leukopenia, thrombocytopenia, etc. And the most important, a large number of patients will be presented with the fever, clinical conditions, symptoms of fever, which is often presented as a fever of unknown origin, pyrexia of unknown origin. In childhood, that incidence of the fever as a presenting symptom increases up to 46%. So that's the important thing. Then the other clinical presentations, skin presentations, it's again around 71%. The patient would have that acute cutaneous lupus, one of the most reliable clinical criteria to make the diagnosis of SLE. The different sorts of the skin presentations, they constitute around in 80% of the patients, you will be able to see that. Most dangerous would be patients who have the renal diseases. 21% of the patients having that renal diseases. Vascular pathologies, blood vessels being constricted, Raynaud's like phenomena. That's the other way. Now, in general, patients who are presented would be majority of the patients will be in the young and relatively active phases of life, middle age. 35 to 50 is the most common group, and that makes SLE more troublesome. And moreover, the clinical presentation would be comparatively milder in younger age, more moderate in the uh, compared severe in lesser number of patients, mild in the majority of the patients, and hence clinical diagnosis of SLE itself is a very difficult job, not a simple job. So most of the times the clue for making the diagnosis will be based upon the clinical presentation, and then you'll have to search for the evidences. That evidences again, the ANA is the most anti-nuclear antibody is the most reliable method of making the diagnosis, but still it may not be positive in all cases. So you will have to have the clinical scoring, and the clinical criteria is the next issue. Even if it is ANA negative, then you will have to make a diagnosis based upon the clinical score, where at least one clinical criteria is met with, you can have a clinical SLE classification. Now based upon the standard criteria would be, it's not that all that point I would be making out is only that much. ANA investigation is reliable, but it's not all. Ultimately, the diagnosis depends upon the both that ANA as well as the clinical criteria. Suppose if the clinical criteria is more prominent, then even if it is ANA negative, diagnosis of SLE is to be made out. That's all the important point. But from the clinical or treatment point of view, management point of view, uh, from the management point of view, it's important to have that clinical assessment, the clinical domain of SLE. Clinical domain of SLE is mainly the constitutional domain, then the cutaneous domain, arthritis domain, neurological domain, serositis domain, hematological domain, and the renal domain. These are the important things. And then, of course, from the investigational point of view, when you have anti-nuclear antibodies present, then complement protein that is seen, not a very important criteria. Highly specific antibodies are seen, where you'll have anti-DNA antibody. Investigation of anti-DNA antibody again is a very costly process, like, and very elaborate process. So in majority of my patients, I don't go into this level of investigations. Once I see ANA positive and there is a clinical criteria, I will be taking that case as a SLE. And a good number of patients who come to us for ayurvedic treatment would already have some investigations done earlier, and hence that burden of going for the investigations would be lesser in a good number of patients. Only a few of the patients where you make the diagnosis for the first time, you need to have these investigations as such. Now, approach to the treatment, from my point of view, approach to the treatment is the first is constitution domain. Majority of the patients present in that constitution domain where the fever is the clinical symptom. Important point could be 15% of the pyrexia of unknown urgent patients end up as SLE. Many times, patients may have fever, they are treated, they are investigated, and so on in many other hospitals, and a large number of patients they end up in Ayurvedic hospitals. In such patients, almost 15% of the patients they may end up as SLE if you go into the investigations in this direction, in the direction of immunity. Then a patient presenting with the fever in a SLE, again, whether it's a really constitutional domain of the SLE, whether it's due to that SLE toxicity itself, or whether it is due to a indolent infection. Patients are more prone to develop the infections, and hence that need to be assessed carefully. There you need more clinical examination. Many times the patient may have a pulmonary infection, and that infection could be the cause for the fever, and this need to be ruled out before we confirm whether we follow the treatment of fever for the treatment for the fever alone, or do you need to have some other collaborative treatment. Then in the patients who have the fever, risk of involvement of other systems is quite high. Other systems like renal or cardiac is very high. High SR and CRP levels are warning signs. These are conditions where you will have to be very careful. Like now, treatment. Suppose you, I have a patient at SLE, and only that fever is the presentation. Other, that's the constitutional domain is that other organs are not involved in that condition. After ruling out the presence of other infective conditions, my approach to the treatment would be based upon again the Dhatugata Jwara Lakshanas. If it is a Rasadhatugata Lakshana where the patient would have Guruta, Hridaya Krosha, Sadanam, Chadanam, Saha, these are occasionally Raktanishtivan up to that level. It could be Mrityunjaya Amrita alone, and this can produce a significant change in the total duration course of the condition. Many of the patients who are treated with the unnecessary burden of other medicines, they have recovered very well with this kind of an approach. Whereas a Gambhira, still Rakta Dhatu Lakshanas, where you'll have more of Pindika system Uttapunisha, muscle pain and so on, and as well as the system, these hematological disorders. Either it's Arogyathanya or Kamaduga added, and when the patient has that cramps and pain in the joints, muscles, tenderness in the muscles, Mamsagajwara, my treatment would be Kaisharukul and Chakulakukul is added to Mrityunjaya Amsaristam. Mrityunjaya Amsaristam is the basic treatment. When the patient has a still deeper involvement, gastrointestinal tract abnormality, Vireka, Chhardihi, this again is a common presentation, diarrhea, vomiting, or improper food digestion, etc. In that condition, Ananda Bhairavi is added. These are the conditions which we can treat with the Ayurvedic treatment. But if the patient has a more systemic toxic signs, toxemia signs like Vikshepanam Gatranam, convulsive conditions, or Tama Praveshanam, unconsciousness, or if the patient has a real pyemia, these are the conditions where standalone Ayurvedic treatment would not be sufficient, and I would be preferring either the patient to be shifted to other hospital or preferring other alternative available facilities. So I don't say that such patients can be treated with the standalone Ayurvedic treatment. But in the other conditions where the patient has the constitutional domain alone and the other systems are not involved, secondary infections are ruled out, and if the patients present with the up to the Mamsagata Jwara Lakshanas, or even up to a certain extent Medogata Jwara Lakshana or Astigata Jwara Lakshana, we can treat with our treatment, but beyond that, it may not be possible. They are asadhya as such. So that's about the constitutional domain or fever domain. Now, the other condition is the other domain of SLE is a cutaneous domain. And as I said, more than 80% of the SLE patients will have the skin signs. And that makes the diagnosis easier. The typical skin signs are the seen in 80%. And quite important is only 30% of the skin lesion, patients with the skin lesion may have only the skin lesions, whereas the remaining would tend to have multi-system involvement. Other domain also would be there. So systemic involvement makes the most critical issue, and it makes the issue more complicated. So patients presenting with the skin sign, we have to be more careful. Now, the usual clinical skin signs of SLE either could be acute SLE, which I consider as the Pitta Lakshana, subacute SLE, where you will have a bit of thickness, that the lesion will be thicker, raised, and slight scaling also are seen. That's the Kapha Lakshana. When a chronic SLE presentation, where it may have an induration at the area and slight tendency for the ulceration, vasculitis also could be seen. That's the Vata Lakshana. When there is a very frank ulceration, which is an intermittent SLE feature, that's the Tridosha Lakshana. And there are the other non-specific lesions of SLE. The specific lesions of the SLE are the typical malar butterfly-like lesion, and then the other lesions are characteristic. These are the non-specific lesions where the patients of SLE may even present with the vasculitis or the typical lupus hair, where the hairs become thinned out and the scalp tissue becomes very transparent, rather shining, like smooth. The keratin tissue layer becomes reduced. Or it could be spotty alopecia with irregular patchy lesions. Mouth ulcers also could be presented as such, which I consider as Pitta Lakshana. Or photosensitivity also could be a presentation of SLE, which I consider Shita Pitta Kapha Vyati. Now, my principle would be based upon the Dosha Lakshana, but very specific only in standalone cases, in the sense the other systems are not involved. Involvement of a renal condition in a case of SLE makes the prognosis poor, and there the skin lesions will be secondary issue. When you are very sure with the investigations like the renal system is not involved, then my prescription would be Kaisharogukul Lagu Sutsekar Kamatuga Manjistarikwata Kathirarista based upon the dosha lakshanas as I have presented with that images. Or Vilachana could be another very uniform treatment in majority of the conditions except that hair loss or the typical SLE hair conditions. Then the next is the arthritis domain, another very common condition. SLE patients, a large number of patients, they present with the arthritis conditions, and the typical arthritis presentation would be when you do not have a typical presentation of rheumatoid, where the deformity is not typical rheumatoid deformity. Rather, it could be like a more of a flexor deformities seen, and more of skin signs around the joint. The joint has shown inflammation. In the X-rays, radiological investigations also are very careful, are very typical in SLE. There will be erosion of the bones at the metaphyseal end. This is very typical. Uh, at the end of the metaphysis, very close to the joint, there will be erosion of the bone, and that erosion of the bone is characteristic of a radiological feature of SLE arthritis. And then my prescription will be almost on the same lines as that of the rheumatoid pathology. Kaisharogukulu, Mrutyunjaya, Amtarishta, Agnichikitsa, Ksharavasti. From my point of view, both of them are Brahma condition, and hence the approach to treatment would be the same. Outcome would be depending upon whether the other systems are involved or not. If the other system like renal system is involved, naturally the outcome would be poor. Whereas if it is not, definitely yes, we can produce a significant benefit. I don't say that it can be cured. I don't say that SLE can be cured completely, but patient can have a better clinical resolution and patient can continue with the ayurvedic treatment. Now, another danger area in all cases of nephritis is, in SLE is nephritis, when there is involvement of the kidneys. This is one of the difficult areas from the clinical point of view, because one, the approach to the diagnosis will be quite difficult, and grading and risk assessment also is quite difficult, and outcome is comparatively poorer. Now, our classical approach would be the diagnosis has to be based upon that multisystemic approach, where you need to, the primary investigation would be the urinary these protein studies. That would be the most dependable primary investigation which can be done in any laboratory. So once the patient has that proteinuria of any grade, mild or the other way, then the patient needs the other investigations important, even it may end up with the renal biopsy. So most of the times what happens is, once the patient has a renal involvement, as we may not have that infrastructure for the renal biopsy many times, you may have to refer the patient to somewhere and the patient may end up. So, treating of cases of lupus nephritis in that category, early category, would be lesser. Whereas the patients who are already diagnosed as nephritis end up with the chronic renal disease, and where the patients may have that adjuvant treatment already, or even dialysis could be indicated. When such a patient comes for IV treatment, again the outcome would be poor, and those renal supporting treatment from the contemporary system would be inevitable. I don't say that a standalone IV treatment would be possible. Of course, we may produce a change in the total clinical course of a patient who is on dialysis or who is having a chronic renal disease. We can reduce the progression, but that's not a very standard protocol. So I prefer to use Chandraprabha Mrityunjaya Samsarista, Chandraprabha Punanamno Rasanadi in such cases as an adjunct prescription, not as a primary prescription. Again, if at all we have diagnosed a patient in the early stage and it's limited to focal or diffuse nephritis alone, still, we may try with our treatment, but if the patient has a clinical evidence of acute active lupus nephritis, the major evidence of active lupus nephritis is hypertension, peripheral edema, or cardiac decompensation signs. That's a condition where you have a high risk condition, outcome would be poorer. So I would be preferring that patient to be referred to other center than really making him depend on only Ayurvedic treatment. I may prescribe Ayurvedic treatment as an adjunct prescription, but it may not be a complete standalone treatment as such. Then very severe peripheral edema, ascites, pleural and pericardial effusions that are suggestive of still more grosser damage, membranous lupus nephritis, where the outcome would be poor. So, renal domain of SLE is one of the red signals in the treatment. Then, hematological domain of SLE, comparatively, the incidence would be leukopenia or neutropenia or lymphopenia or thrombocytopenia. Now, among these, the approach to the treatment is based upon the severity of the condition. A severe thrombocytopenia may result in acute bleeding conditions, or very gross leukopenia also may require emergency conditions like transfusion. So, whenever we handle these patients, it's important that we have to be careful and be ready for meeting with the complications, infections, and particularly patients with the leukopenia and neutropenia. They are more prone to produce the infections, and some of these infections may produce a sudden, unexpected change in the course of the disease. A apparently seeming to be mild respiratory infection all of a sudden may result in a severe pneumonia, and the patient, you may either have a very critical condition in patients with leukopenia. So patients of leukopenia being treated, we have to be more careful, and in such conditions, when the patient becomes critically pneumonia-like conditions, standalone Ayurvedic treatment may not be enough. So there, I may prescribe Arogyavardhini Kumarayasa as a co-prescription, and depending upon the other intensities, severity, you may need to have a collaborative contemporary prescriptions. Then the next is the neurological domain of SLE. Among the neurological domain of SLE, the more common conditions are neurovascular disorders like seizures, meningitis, etc., movement disorders, particularly movement disorders, different sorts of the movement disorders, which are diagnosed with a different approach, like either it could be diagnosed as a stroke or diagnosed as Parkinson's conditions. There could be a SLE as an underlying pathology. Psychiatric symptoms also are quite common. Peripheral nervous system involvement like a neuropathy or even myasthenia can be presented. But when a patient comes to you now, what we see quite frequently would be either the patients come to you with a history of stroke, because patients with the stroke conditions, they usually end up in Ayurvedic hospital, or patients with the nerve root compression or myelopathies, different sorts of the myelopathies. Now, if you look at the MRI scan, it's quite important. The MRI scan shows that high density white substance deposits, which is very characteristic of SLE. Unlike that of the other stroke conditions, the cerebrovascular vascular accidents, they will either have a lacunar infarcts or hemorrhages. Whereas you have that whitish deposit seen in MRI, that's almost confirmatory of SLE lesions. And it's quite interesting, like I have seen many radiologists might have missed this, and successfully, if you keep this in mind, many times we can make a specific diagnosis of such patients who are misdiagnosed or treated diagnosed earlier, and the SLE is missed. Now, from the treatment point of view, of course, there is not much of a very significant change in the approach to the treatment. The treatment will be based upon the other clinical signs, but in these cases, I will be always preferring a Pachana Chikitsa like Agni Chikitsa more preferably than the other way, the usual treatment. So that's about the neurological domain and SLE as such. I have covered all the domains of SLE in brief, based and a bit of the clinical experience. Next up, the condition is the psoriasis. Psoriasis, ICD coding is L48.9. Incidence of the psoriasis, prevalence, also comparatively lesser in India. The India is not in that high density zone, whereas Australia and other countries, it's in the higher density zone. So incidence of psoriasis comparatively compared to other countries, it's lesser. Now, diagnostic criteria for the psoriasis is the scale and erythema in the scalp involving the hairline, or scaly erythema inside the external auditory meatus, persistent well-demarcated erythematous rashes anywhere in the body, persistent erythema in the umbilicus, scaly erythematous flakes in the extensor surface of the elbows or knees, well-demarcated erythematous rashes in the napkin area involving the pleural fold, and or family history of psoriasis. These are the standard diagnostic criteria. So a patient presenting with a chronic scaly skin lesion, you have to confirm about that. From the clinical point of view, the psoriasis again could be categorized into many varieties based upon the clinical presentation. Either it could be stationary, plaque psoriasis, gutted psoriasis, inverse, pustular, erythrodermic, and so on. But for the clinical presentation and assessment, the criteria would be the scoring. So to present the assess the scoring, a preferable scoring method would be the PSI score, where the area and the intensity is a psoriasis area scoring system. Based upon the surface area, it could be like arm, skull. These are given score 1 B1 and 0 to 6. So in the arm, we divide this head into 6 zones and 0 to 6 score, arm 0 to 6 score. So this way we have to calculate, and intensity of the pathology can be made out. From the point of view of clinical assessment and then planning the management, more important is the pattern of the lesion than really the extent. Many times the extent is not a very important criteria from our Ayurvedic treatment point of view. Of course, the patient may have more severity, patient may have a negative approach in when there is an extensive lesion, but from the outcome point of view, this assessment is more important. When the patient has erythema or redness, that's the one of the important feature. And then again, based upon the erythema, you may score this like erythema being absent to very severe. Erythema is a sign of environment of the pitta, and I would be grading that pittaja vyadhi based upon this criteria. Whereas induration, the kaphaja vyadhi lakshanas, kapha lakshanas, and that thickness of the lesion, again I would be using the same scoring method, the scoring psoriasis severity scoring method for either pitta, kapha or vata. Scaling, discrimination scaling, more the scaling, more vata score and lesser vata score. Preference of the drugs which I select in case of the psoriasis would be based upon this criteria, though it may not be in the objective form of a scale, number of scales like scale 4 or so, or it could be on the same lines, and most of the patients will have all the Tridosha Lakshanas. Now, treatment would be, my prescription would be, or the identification would be, if there is a psoriasis vulgaris, usually, now based upon the type of the psoriasis vulgaris, plaque psoriasis, nail psoriasis, or the line psoriasis, that among those types which I have mentioned, they are mainly of the Vataja variety or Vata Kaphaja variety. Now, from the textual point of view, the psoriasis, these could be either the Kapala or Rishyajihva or Pundarika or Ekakusta or Charmakusta. And my treatment in these conditions, these category of conditions, where in general there is a Vata predominance. Now, there could be slight exceptions. Many times, a plaque psoriasis may also present with the Pitta Lakshanas. That's possible. But majority of the conditions, it could be the Vata Lakshanas and or Vata Kaphaja Lakshanas. My treatment would be Kaishwara Gugulu, Lagu Sutashekara, Khadirajistra, and Virechana. Virechana is a very standard protocol for majority of the psoriasis conditions. Then the Pittaja Lakshanas are seen in mainly gutted psoriasis, inverse psoriasis, eruptive psoriasis. Gutted psoriasis is characterized by more reddish localized eruptions and more than itching. Patient may have a burning sensation in the area. Inverse psoriasis usually in the folds of the chest, and they have a periphery which is highly reddish or thickened, and the lesion will be expanding peripherally, which often mimics that of a fungal infection, but a typical fungal infection of a central zone of clearance, whereas psoriasis lesions would not have that central zone of clearance. So clinically, it has to be carefully assessed, and these are usually considered as a Pittaja or Pitta Kaphaja Lakshanas. And in these conditions, my preference of the treatment would be Aragyavardhini, Kamaduga, Manjushtati or Sarivadhyasva, Virechana or Vamana. More frequently it is a Virechana than the Vamana as such. Then the patients with the presenting pustular, scalp psoriasis, oral psoriasis, usually you will have more rough indurated lesions. Either they could be mandala conditions or alasaka or dadru mandala conditions as such. And Kafaja or Kafapittaja, my preference of the treatment would be Kaishara Gukulu Gandakarasana Arogyaratini Khadiradista. Vamana is generally more preferred or Virechana. With the Vamana, number of Vamana patients are comparatively lesser because of the troublesome, or patients may not easily accept that. So, in such conditions, I would be preferring Virechana as a alternative to the Vamana, but that's also good enough. The Tridoshaja, or where you have more complications, would be severe erythrodermic psoriasis, which is typical of a Gambhira Dhatugata Kushta, either Mansaja, Medaja, or Astimajagata Shukra, the Kushta conditions, where patient would have a psoriatic arthritis. Outcome is very poor. Of course, outcome is poor everywhere, and the treatment would be, my preference would be Kaishora, Mrityunjaya, Khatirarishta, as such. Rasamanikya is another secondary line of treatment, particularly in erythrodermic psoriasis. It can produce a significant change in the outcome, though it may not be very dependable. Virechana or Vamana is the other standard protocol. Of course, Natkin psoriasis, mainly in children, and they are more than your prescription. Contact has to be avoided. That's about the psoriasis. The next of the condition which I would be referring to would be autoimmune thyroiditis. Uh, ICD coding 86.3E. Comparatively, incidence of iodine deficiency goiter or iodine deficiency thyroiditis is more common, and sorry, rather, in India, hypothyroidism produced due to iodine deficiency is more common than autoimmune thyroiditis, whereas autoimmune thyroiditis is more common in Western countries. So that's all the important thing. So many of the patients who come with that thyroid abnormality, features of thyroiditis in our conditions, you need to be careful. We may not follow the usual textbook guideline of autoimmune thyroiditis. Uh, Another very important thing is in the present day situation, incidence of abnormal thyroid function has become a very common condition in the younger generation, particularly younger females. Almost every person whom you investigate for these thyroid function tests would have a normal T3 to 4 level. TSH level would be raised, which I would consider due to the consequence of a lesser activity, reduced activity, exercises being lesser, and the food habits, lifestyle is more common than really the thyroiditis. Many times patients are investigated overzealously of that category, and they are made to depend upon a hormone supplement unnecessarily. So that is another area of a different sort of perception. Anyway, because we are discussing about autoimmune thyroiditis, it's a contextual issue. But once you have a patient of autoimmune thyroiditis, the clinical presentation could be based upon the involvement, and the involvement is usually categorized into the atrophic thyroiditis, juvenile thyroiditis, or postpartum thyroiditis. Now, postpartum thyroiditis is one of the major areas of concern, and incidence also is quite significant. Then silent thyroiditis, where the patient may not have any clinical symptoms, only on the investigations you will see them, or focal thyroiditis, where localized lesions could be seen on scanning. Of course, ICD group is something different, where of course it's the same feature, but the clinical presentation would be Hashimoto's thyroiditis. Hashimoto's thyroiditis is characterized by an initial stage of hyperthyroidism and then a hypothyroidism, later hypothyroidism, or it's also called as Hashimoto's transient, lymphadenoid goiter, lymphocytic thyroiditis, or struma lymphomatosa, which is the ACD categorization, which requires a histopathological assessment. So biopsy would be required to make out this. But in majority of the patients, you may not need it as such. Now, from the clinical approach point of view, it's important, like majority of the patients, they are presented euthyroidism and goiter, only a localized swelling, but T3, T4, TSH levels are normal. A subclinical hypothyroidism and goiter, the next category. And there again, you may have a primary hypothyroid failure, hypothyroidism, adolescent goiter, painless thyroiditis. These are the conditions comparatively less common. We do not see them quite frequently in our area. What we see, majority of the patients are patients with euthyroid and maybe moderate goiter, subclinical hypothyroidism and goiter. Postpartum painless thyrotoxicosis also, though I don't say the incidence is quite high, but there are one areas of concern where you need to be more alert, and treating that condition is absolutely essential. Then alternating hypo and hypothyroidism. Patients at times may have hypo features, at times may be hyper features. In thyrotoxicosis, it is common. Like initially, Hashimoto's thyroiditis is more common. Initially, patient would have a hyperthyroidism. Later, the patient may have a hypothyroidism. In these conditions, the investigations will be mainly the TSH, free T3T4, and thyroid peroxidase or thyroglobulin antibodies would be required. These two, thyroid peroxidase and thyroglobulin antibodies, may be reserved for only when you have a real suspicion of autoimmune antibodies. Now, when we go for these investigations, as I said, you will have a plenty of patients where the TSH level will be higher, but T3, T4 levels are normal, and there you need not concern and do not have to make them thyroid dependent. Whereas postpartum thyroiditis, after the delivery, there could be a significant change in the total thyroid picture outcome. It could result in multiple complications. Either it may result in a postpartum Graves' disease, or patient may have a persistent autoimmune thyroiditis also, and hypothyroidism can occur. And that postpartum thyroiditis is one of the major areas, risk as such. You have to be very careful, and assessment and maybe a early thyroid replacement, thyroxine replacement may be justified in that condition. So if a patient of postpartum thyroiditis comes in, I will follow all the guidelines of the contemporary system than really my prescription. In other conditions, like if the patient has that normal T34 but raised TSH, the best and most reliable treatment would be pranayama, regular exercise, avoidance of junk food, particularly the ajinomoto, the preservative which is added to the food is the major cause, and those who eat these pizzas and so on, they are more prone to develop this kind of phenomena, and they do not require a medical treatment at all. A lifestyle management with pranayama and avoiding these junk food, regular exercise can make a large number of younger generation patients, persons who have that normal T34 but slightly raised TSH as normal, and we can avoid the supplementing with the unnecessary burden of the hormone replacement. If at all the patient has to be treated, I would be preferring a Dhapagni Mandya treatment, Aragyavardhini Kumaryasava, as an Agni Vardhana or Dhatu Vruddhi protocol is the Agni support to the Agni. A patient with borderline clinical symptoms like slight hair loss or a slight variations in the menstrual cycles, not very high weight gain, and so on. So such moderate borderline clinical symptoms and the normal T4 levels, my prescription would be suitable same protocols plus suitable agents like Rajapravartinivati, Draksharista, depending upon the clinical presentation. If the patient has anemia, it could be Draksharista. If the patient has excess bleeding, it is Uchirasa. If the patient has delayed cycles or amenorrhea, Rajapravartinivati, Kanchana Ragugulu, if the patient has a visible goiter, along with the Aragyavardhini Kumaryasam would be my choice of treatment. If the patient has a marked hypo or hyperthyroidism, rather hyperthyroidism is more critical than hypothyroidism, in that condition, I would not prescribe Ayurvedic medicine alone, rather they would be prescribed as a co-prescriptions. Prescription would be the same, but either it's a thyroid suppressant drugs in marked hyperthyroidism or marked hypothyroidism, it could be the thyroxine. Now, that's about the thyroiditis. With this, I think the time is up. So, let me conclude. And though I think I have not dealt with all the autoimmune disorders, but major autoimmune disorders which we treat in our conditions, I think I have referred. And the conclusion would be, carry home message would be, autoimmune diseases are evolving clinical entity in contemporary medicine, but whereas from Ayurvedic point of view, they are well known, and we have an established setup or established information about that autoimmune disorders. Principles of autoimmunity are described in Ayurveda as Dhatupaka or Rama. Ayurvedic protocols of treatment can be safe and effective when they are used as a judiciously. And the last two important statements which I would repeat is Vikarana Makushalaha Nadishyat Kadajana nahi sarvavikarana namatosti dhuvastitihi. This statement is very much relevant in the context of autoimmune disorders because the number of autoimmune disorders is just continuously increasing. Then the last is natam parimita aharaha labhante vichiragamaha मूढ़ाः ताम् अजितात्मानः लभन्ते कर्मशाशयाः. Maintenance of a discipline about the diet and the lifestyle can prevent the clinical presentation of autoimmune disorders. With this, let me conclude. Thank you. If there are any questions, I think there could be some questions. Uh, okay, thank you.
Thank you very much, sir.
Right. Sir.
Sir, thank you very much for this wonderful session. It was very simple and explained in a so beautiful ways that relating to the Vatpit Kapha, every autoimmune disorder is explained, which are relevant nowadays and we are seeing in our daily routine practice. Sir, there are few questions from our
Right.
delegates. With
Okay.
your permission, can we ask, sir?
Okay. If there are any questions, I try to
Yes, sir.
answer.
Yes, sir. So, can we totally cure autoimmune diseases like SLE, etc.?
No, I have already clearly told there is no question of a complete cure in case of an autoimmune disorder because the basic underlying condition is a genetic predisposition. We definitely can reduce or avoid that triggering factors, and the clinical course of the disease can be completely suppressed or avoided. And now the controversy is the same. Like if the patient has some abnormal lymphocyte generations, like see T lymphocytes, you can bring that T lymphocyte level to normal number. But if there is a abnormal lymphocytic generation, if there is an abnormal DNA identified, if from the technical point of view, the patient is not cured, though the patient doesn't have any symptoms. So that's why I say I cannot cure a patient of autoimmune disorder, but patient can be completely having a normal activity, normal life. Clinical cure is possible. That's the target, right? Right.
Okay, sir.
Right.
So, next question. If the patient is already on contemporary medicines, should we withdraw them or start only our Ayurvedic medicines?
That's another very difficult question, of course. It's very difficult to answer that question as a straightforward, simple answer. It depends upon the clinical presentation of the patient and the presence of systemic complications. See, in general, if the patient has a severe renal pathology and there is a renal supportive treatment otherwise, I would not dare to change those treatment. That treatment will be maintained. So we'll have to have a thorough knowledge of the pharmacology of the contemporary system, and then only you can think of either whether those drugs can be stopped or not. And it also depends upon the status of the patient. Steroids they cannot be stopped all of a sudden. They need to be tapered. Whereas the contemporary generation, the present generation, like drugs like target-oriented drugs, they can be withdrawn easily. Then the self-repairing like drugs, HCPS drugs, like drugs, the disease-modifying drugs, they can be easily withdrawn. So whether we can withdraw those drugs or not depend upon the type of the prescription and the status of the patient.
Okay, sir. So, one more autoimmune disorder, Sjogren syndrome. So,
Ah,
what would you like to say about it, sir?
it's exactly like that of the rheumatoid pathology, except that there will be involvement of the conjunctiva infiltration. So, from my point of view, every autoimmune disorder is a ama vyadhi, sama vyadhi. Now, and the prescription will be within this. Whatever I prescribe, the drugs will be within this. The
Okay.
changes, there could be a slight change in the pattern, these combinations like duration of the treatment, approach to the treatment can be varying, but otherwise, any sort of autoimmune disorder, my prescription would be within whatever we have discussed today. I would not
Okay,
have any
sir.
other drug. That's
Okay.
what I treat like. So that doesn't mean that it's a complete treatment for everyone, right?
Okay, sir. So, one very important question, which is usually asked, allopathic medicines or allopathic doctors generally advise immunosuppressants in autoimmune disorders, and whereas we Ayurveda practitioners suggest immunoboosters. So, how to manage such conditions? It is a bit controversial. One is immunosuppressant and one is
Okay, I got
immunobooster.
it, got it. See,
Yes.
now I never call our Ayurvedic drugs as immunoboosters. I use the word immunonormalizers. So it's neither boosting nor reducing, it's normalizing. Ayurveda is for normalizing. So it's that dosha samata is the treatment, not that it's boosted or other way. So I never use that word immunobooster. So that from my point of view, that's a misperception. So I will never use
Okay.
that word. So it's immunonormalizer. So there is no controversy. If you say immunonormalizer, there is no controversy. The
Okay.
controversy will be when you say immunobooster or immunosuppressant. Is it?
Okay, sir.
Right.
Yes, sir. Sir, one of our patient who was on methoxyrate, when we tapered it,
Yeah,
sir, his
method,
platelet.
see, methotrexate can be definitely stopped abruptly.
Yes, sir. Sir, the next condition which arose is his platelet count continuously went down. And when he stopped our medicines and again he was on steroids, it was okay. So then this question arises, how it's happening. And we lost that patient because of this reason. He was not satisfied.
That's what I said. Like, see, one is patients be on steroids. It cannot be stopped. See, patients on steroids, it cannot be stopped all of a sudden. You may modify the dose, reduce the dose, depending upon the patient's response to the treatment. Then patients with that hematological pathologies, leukopenia or thrombocytopenia, there is always a risk of developing some secondary complication. You have to be very careful. If there is a severe sudden toxemia developing, our treatment alone would not be sufficient. So that's one thing. And another thing which I have not really mentioned is patients with renal involvement. I would not give any neurohebastis. Once the patient has neuropathy, the risk in a patient of renal pathology, the complications, I have met with a few complications, rather I have lost a few patients also because of that. So at present, I am not giving neuropathy in any patient where there is a renal involvement. So that's another of the issue. So many times we have to learn certain things on some patients as such. So withdrawing the drugs, methotrexate withdrawal doesn't produce any serious complications
Sir,
except
it
that
was tapered. It was
yeah,
not withdrawn. It was just
no,
as tapered and
yeah, but
discontinued.
steroids it cannot be. And one and another is that patient might have developed some septic complications which might have been missed and which cannot be just managed with our medicine alone. Suppose a patient develops an acute septic complication, toxemia, severe consolidatory pneumonia. It may not be possible to manage that patient with our treatment alone. You may need to have the other system. Either you may prescribe the drug or you may have to take the help of others. If it is ethical discipline, would be refer the patient to elsewhere, or maybe if we have that competency, we can treat that. So I do prescribe those contemporary medicines to the limit of my possibilities. Right?
Okay, sir. Okay, sir. So the next question is, usually autoimmune disorders are chronic. Then how long should we treat those patients continuously in the
Not,
follow-up?
not necessarily. See, not necessarily that every autoimmune disease is chronic. Many of the autoimmune disorders can present as acute conditions too. And what I have seen is, see, conditions like rheumatoid arthritis. It's almost lifelong. It's a Yapke. It's obviously Yapke. Psoriasis, it's almost Yapke. So it's you need to continue the treatment as long as the patient is there. But a patient with the febrile conditions, constitutional symptom of SLE, the patients can be easily managed and we can withdraw the treatment. Only the thing is there is a risk of recurrence in such conditions, and the patients are particularly SLE with the history of fever, they need to have. I would be just keeping a watch on such patients, though without any medicines. Once in 6 months or so, I will be having the urinary albumin level assessed. If there is even a microalbuminuria, then the patient has to be reviewed. And diet restrictions and exercise are very critical, by which you can really prevent the recurrence. So even in such patients, though we may stop the treatment, we have to be watchful, and this has to be educated to the patient. This issue has to be educated to the patient. We can withdraw the medicines. There are plenty of patients where we can withdraw the patient medicines. Other than those so-called yapia.
Okay, sir. Sir, most of the autoimmune disorders which are passing on from one generation to another, how to prevent that autoimmune disorder to be in progeny, in the upcoming progeny, how to prevent it during the Garbini Charya, or how we should do it?
Yeah, see, I think I have already partially answered that question. See, it could be a genetic predisposition, but the disease will be presented only when there is a triggering factor. And that
Yes.
triggering factor, as we know, and the maximum amount of information of the triggering factor is about the food and the lifestyle, diet and lifestyle. If you maintain that diet and lifestyle, clinical presentation, triggering of the disease can be definitely prevented. And that genetic predisposition, as long as it is subclinical, you don't have to worry. And nobody goes for the investigation unless they have a clinical evidence. Now, very advanced approach like a patient family history, you may go for the investigations, and then you may find a genetic predisposition. But there too, if you take care of these issues, definitely it can be prevented. And when I say this, these autoimmune disorders, number of autoimmune disorders are increasing. See now, type 1 diabetes mellitus, ICD coding itself has now categorized one category of one group of type 1 diabetes as a autoimmune disorder. And one of the standard protocol of investigations in type 1 diabetes is go for that lymphocyte assessment. So now this is the controversial issues, or rather maybe troublesome issues. Variety of autoimmune disorders, names of the autoimmune disorders, they are increasing very rapidly. And one or other day, maybe in future, you may have a situation where every disease may be considered as autoimmune, even possible. Ama produced value. So the principle is coming closer to the Ayurvedic concepts from that point of view. So there, in such a situation, this kind of perception, like preventing the triggering and making the condition as a totally only non-clinical or where clinical presentation is avoided, that itself would be enough. So that kind of an approach would have a relevance. It's not that it's a just a poor alternative. It's a very relevant factor. I think I have clarified that.
Yes, sir. So next question. Many patients have RA and hyperthyroidism both simultaneously. What are the guidelines for pain management and Agni Chikitsa? And there is one more question regarding this. Agni Chikitsa guidelines, what should we follow?
In Agnish case, it's a rather patented combination from my SDM magic point of SDM hospital, based upon some folklore practices where we have six these raw drugs and seven crude dry drugs put together and applied over the as a paste over the area. It's a sort of pachana chikitsa. It's simply a sort of pachana chikitsa. And during that course of the treatment, we avoid all protein contents like milk and milk products are avoided. Patient is kept on only ganji. So it's simply a pachana chikitsa. And then the other is the ksharavasti, which also is a pachana vasti. So dosha pachana, considering that treatment of ama and that ama pachana is the major course of the treatment, right? So Agni Chikitsa is what we prefer in our hospital because we have that established in large number of patients. It could be any other alternative. You may think of any other alternative. It could be this Shuntik Shirabaka. So in some of the areas, they use that Shuntik Shirabaka as a patent chikitsa. Absolutely right. It could be, but my experience and my this clinical information is limited to this kind of a protocol.
Okay, sir. Sir, in this, we can include the Ushnavirya
Which one?
Aushati, Ushnavirya Ahar in this regime,
Ah, right, Ushna Virya, fine, that's true, but primarily Pachana. It's not necessary that every
like
Ushna,
Shunthi.
yeah, every Ushna Virya Dravya should be Pachana. So you need to
Okay, sir.
select those drugs which are deeper Pachana.
Okay, sir. Okay,
Ushna
sir.
Virya, of course, is true. Right.
Okay, sir. Sir, what drugs we can buy for the Agni Chikitsa?
There are five raw drugs. Agnimantha. Pavata is what we say, Pavata indica. That's one. Krishna Tulasi. And then, yeah, uh, yeah. And then sorry, Neki, that's Vitex
Nirgundi.
Nirgundi.
Yes, sir.
These are the main raw drugs made. Then the dry drugs are uh, Trikatu, all the Trikatu is added. Then Billuli, that's Rasona. Uh, yes. Uh, then Jiraka is added. We make a paste of this, and this paste is applied over the surface of the body, and the A slight small quantity of the paste is already also given to the patient orally. And throughout the patient course is given for 7 days. And throughout the course, the patient is given only ganji and maybe the khichdi, liquid diet. No other solid substance is given. Semi-solid substance is given throughout the course. And
Sir,
this produces significant relief in the all the AMA conditions. And this is a very standard protocol which we use in case of stroke patients also in initial stages and the different sorts of the AMA values, right? So,
and sir, the Krishna or Khichdi is considered as Abhishandi.
no, no,
So,
no, no. It's not Abhishandi. It's Laghu Ahara. It's
okay.
only Ganji. Or
Ganji is
Khichdi.
prepared from
Only
rice,
rice and
boiled
water.
rice.
That's all. Real.
Okay. In North India, sir, it is Khichdi is like with pulses and moong dal
You
and this
see,
thing.
that's the only thing. Instead of rice alone, you may add some pulses to the khichdi. That's all. Otherwise, it's a what sort of ganji only. Real. Semi-liquid is given. What we prepare in our hospital. Right. Not that khichdi prepared on the time of some festivals like that you will add ghee and so on. I think that's not the khichdi.
Yes, 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 sir.
Right.
And so the next question is treatment for acute inflammation and weeping, oozing in skin in autoimmune skin disorders like in psoriasis. Sir.
Psoriasis patients, if there is a acute exacerbation, to suppress the exacerbation, you may need either glucocorticoids at times. I don't say that every 100% patients can be treated without that. Rarely, it's not very frequent. In psoriasis, it's not very frequent. But if there is a very severe condition, short duration of glucocorticoids may be required to suppress that. But it's not per se continuous treatment. See, with the glucocorticoids again, if I have to give glucocorticoids in such conditions, like pemphigus, it has to be given. Sorry, pemphigus, I have not discussed in detail, but that's also another autoimmune disorder which we come across. And psoriasis is also very rare acute exacerbations. A short duration of high dose steroids is prescribed, what we call as a pulse therapy, usually for 1 week or maximum 2 weeks, not beyond that. That could be needed very rarely in patients where it's quite severe.
Okay. Sir, some of the autoimmune disorders aggravates in particular ritu. So what
In
in
particular,
particular ritu and kala, in
yeah,
particular
that's
kala.
hmm.
So sir, how to prevent or we should be cautious in those kala? How to should we change the prescription or should we change the modality, treatment modality?
Uh, See, that's theoretically absolutely true that we may have to change the prescription, but practically we don't do that. Incidence of or aggravation of the diseases during certain seasons, seasonal impact is well known. Winter, the pain will be in arthritis will be more. So usually we take the precautions to advise the patients to avoid that exposure to the cold. So it's most of the times is the cold which is the triggering factor. So that's avoided. Uh, as of course, theoretically yes, we can change the prescription, but practically we don't do that. Generally, we manage with the same medicines as it's convenient. Right.
And sir, nowadays, due to more heat conditions and summers, the temperature is raising. People are staying in ACs. Always
Yeah.
they are in AC, and this Amvata is increasing day by day. So they are not ready to leave that AC. So how to counsel those patients?
We'll
Because
have
the
to
factor is still there.
we'll have to educate the patient about that. And mm, I don't use any AC. I don't have any AC in my home. So
Yes, yes, sir.
I think that kind of an advice which you follow, Gandhi's principle, may have more impact than otherwise. So I think Gandhi's principle is that if you have read about that experiments with the truth of Gandhi, there is a very popular story. A mother went to Gandhi with her child who was stealing jaggery and eating jaggery unnecessarily. Gandhi told her to come after 1 month, and after 1 month, and they brought that child to him. Mahatma Gandhi simply told the child, you stop eating this jaggery unnecessarily. Child stopped that. Then the mother asked him, like, You could have told that a month earlier. Why you have delayed that? Then Gandhi told, Mahatma Gandhi told, because I had that habit of feeling this jaggery earlier. As long as I had that habit, my words would not have that weightage. And as I have stopped it, now my words should have the impact, and the child has stopped. So I think that principle is very important. And when we advise the patients, it's quite important that when we advise with that kind of a commitment, that impact would be there. It's very notional. It may not be very objective, subjective, but it is true. My clinical experience says that it is true. When you have a commitment and that committed words, they will have a better impact on the patients. When we do not have a commitment and when we are superfluous, we may use any best word, best expression, but the impact on the patient would be lesser. So, with the patient-doctor relationship, there is something what we call as ethereal, and in that ethereal is this is the one. Many times, many of our students say that "Nimma kai guna." It's not kai guna; it's a bai guna. So, so those where we have a commitment, that commitment will be having an impact. So that part. So when you said about difficulty in counseling, so if you are sitting in AC room and then you tell the patient that you do not use the AC, naturally it cannot have that impact, right? So similarly,
Yes,
it's
sir.
all
Yes.
about the diet and every aspect. It's the same thing is true. And in the classroom, when you go for the teaching, also in the classroom, also it's also the same issue, right? So,
Yes, sir. So the next question is, can we give rasa preparations in kidney disease?
yes, of course. See, that's what I said. Like, you see, whatever I prescribe, it is not the ultimate. And when I prescribe, in total, my practice, I use only about 32 medicines, not more than that. I select the medicines which are comparatively cost effective and easily available, and so on. My criteria are different. So that doesn't mean that the other preparations are useless. Every other preparation which is present in the referred in the our these texts as such, they are relevant. Only thing is you cannot use all 64,000 yogas mentioned in different texts and then have the experience. So when you have to have a deep clinical experience, you need to limit to a few of the yogas and get the experience. So those drugs are those combinations which we are using. But if you follow the dosha lakshanas and dosha specific targets, uh, any medicine can be used, any drug can be used. Rasa Aushadhis are other way. But if you do not have that dosha approach and then have a general notion like such and such prescription for rheumatoid arthritis, then that's not an Ayurvedic treatment. That cannot be having the same results. So where we miss, majority of our practitioners miss is they miss that dosha lakshanas. They follow it as a standard prescription and equivalent this mark is put in, and that makes the total approach something different, not a ethical issue. That's the point, right?
Yes.
I think I have clarified that
Yes, sir.
correctly.
And so the medicines, when the medicines are prepared in Shastrokta Vidhi and proper method is followed, proper standard protocols, I think they will not affect. And Dr. Gopi Krishna sir will also uh, have to answer this question because, sir, this question is again popping up in many minds.
That's obvious true. See, that the quality of the preparation of the medicine is a very crucial issue. That's obviously true. No need of any comment on that part, right?
So the next question is treatment for alopecia.
Again, alopecia treatment will be depending upon the type, the assessment of the cause. See, what I have referred to is alopecia related to the psoriasis only, but or the SLE-like conditions. But when we see the patients of alopecia, the plenty majority of the patients are hormone dependent. These the conditions, hormone dependent conditions, they cannot be cured. I don't have any treatment. That khalite is asadhya. Whereas another very common cause for the alopecia which we see is the fungal infections, where you have a patchy lesions. In that condition, Gandhaka Rasayana, Kaishuru Guru, this treatment will produce a significant result. So when I see a patient of alopecia, if it is a hormone dependent, where you have a very and that itself is a very detailed subject, the identification of that hormone dependent this alopecia. I think if that pattern hairline going up, sparse hairs, etc., that needs to be clarified. And in such conditions, there is virtually no curative treatment. Whereas fungal infections, the next common, we can treat. Dandruff, definitely yes, we can treat. Then hypothyroidism can present with alopecia. If the thyroid functions are recovered, that alopecia would be recovered. So the choice of the treatment will be based upon that assessment. So very important thing is the exact assessment of the condition in every disease. It's not only about the alopecia. In every disease, when you treat the patient, that exact assessment of the disease is very important, crucial. And another important is this assessment need not be only based upon laboratory investigations. You don't have to go for costly investigation process. A keen clinical observation can make a good diagnosis, excellent diagnosis. Many times, the diagnosis could be better than the investigation facilities if we are a keen observer. Uh, Maybe a few of the patients do require investigations, but not necessary that for the sake of investigation workout, you need to make a patient spend a fortune. That's the point, right?
Yes. Sir, one more question. As Kleda and Ama, they are utpatti, reason for the utpatti of krimi. So, can we treat autoimmune disorders on the line of krimi chikitsa, or we can follow that too?
For this question, I think uh, we it theoretically maybe correct, like, but I don't have any clinical experience. Rather, I don't find this argument as a very solid argument. Theoretically correct. I am not saying that this is wrong, but not a very solid. We don't need to go to that level as a see if we identify AMA and follow the line of AMA treatment, we can produce a significant clinical change course in the disease. So, making it more complicated, I think not necessary.
Okay, sir. Okay, sir. So, please put some light on Misthania gravis treatment.
Which one?
Misthania gravis.
Myasthenia gravis. Myasthenia gravis. Of course, in myasthenia gravis, if the patient is on physosigmine, I will never withdraw that physosigmine. But I have treated a few of the patients where even after one of the major problems is patients of myasthenia gravis, they will respond very well to physosigmine. The moment the physosigmine is given, patient would have a normal functions. Within few minutes, you will see the change, and maybe the effect will be lasting for a few hours, and then again the effect will reduce. So the patients usually we do not have any such alternative treatment which we can produce such a change. Like it cannot be instantaneous. But the scope of our treatment comes in when patients are on that drug for a quite a long time, and the patient need to increase the doses, and gradually they become somewhat resistant, and at times it may be like the patient has to take the medicine once in 2 hours. So such patients they come to us. So in such conditions, what I do is I prefer to give a basti, yapana basti, brahmana basti, and usually I give ekanta vinagasa and ashwagandha arista. With that need for extra dose can be reduced. At times, we can reduce the dose to a certain extent. To a certain extent, I had a patient who was taking every 2 hours. I could reduce it to 4 hours. Instead of 10 doses, it could be reduced to 4 doses or 6 doses. So that's significant. But it's not possible to stop that the physosigmine condition completely. And the quite important is physosigmine produces such a relief which no other patient, where we do not have anything which can be comparable to that level, where we see the results immediately. So that's the point. And in such a condition, it's not really justified if we withdraw that drug and put the patient into trouble. Right? I think the issue is clear.
Yes, sir. Sir, please tell some drugs to reduce pain in Amvata, severe pain management. What drugs which we can prescribe?
In Amavata, rheumatoid.
Yes, sir.
I think with the Kaishwara Mrityunjaya Amtarishta, a patient's pain can be relieved very significantly. If there is any need for a symptomatic treatment, pain relief, I will be preferring Vishamustivati or Nabhivati because it reveals. which can help in reducing the symptoms of pain severe. So, very rarely I have used any analgesic in a patient of rheumatoid arthritis. Virtually almost nil. Maybe exceptionally, if we go on to the history, maybe 1 in 500 patients may have prescribed diclofenac or so on. At times, if the patient is giving a lot of trouble at night, maybe I don't say 100%, but very rarely you need other drugs. With our drugs alone, maximum mission COT can help in reducing the same patients. Now, another patients who are admitted in the hospital for rheumatoid arthritis, they suffer about or they complain about the pain more at night. That's more of a functional type, and because of the chronicity, and during daytime they do not just do the exercise, they sleep at daytime, night they don't get to sleep. In such conditions I usually prescribe synthesizer and transposition, not for the pain, but their complaint of the pain is due to the other factor. So once they have that good sleep, that pain will be reduced. So that may be some additional prescription which I make. So usually when I get the call at night, that patient is complaining of pain, my prescription will be either Sinsara Samsara or Vishnusurti. That's all. Uh, and extremely rarely, very rarely, diclofenac, maybe. At times, if there is more than 2 or 3 calls at night, maybe I may prescribe, but not regular, not necessary. Generally.
Yes, sir. And sir, what are the drugs to reduce the avil mutrata tendency in Amvata patient?
Now, Avimutrata in the sense you say proteinuria.
Yes,
See,
sir.
Avimutrata, if there is a definite proteinuria, uh, say albuminuria, I would go for all that battery of investigations, series of investigations, and depending upon the condition, we may require the other supportive treatment. I don't say that the patient can be treated alone without, and of course, in rheumatoid pathology, rheumatoid arthritis, that kind of a issue is comparatively less common. SLEC is quite common, that renal involvement, and it's always an issue, danger area. I would say that it's a danger area. Renal involvement is a danger area, and though we may manage with Punarva but to a certain extent, that's not a complete treatment. A patient with proteinuria need to be investigated thoroughly. Renal functions are the basis. At times, even if we have to go up to the level of kidney biopsy, renal biopsy, and only in those conditions where there is no progressive cortical damage or parenchymal damage, we may manage with our drug alone. But with the parenchymal damage, it may not be possible to manage with our drug alone. Dietary restrictions and exercise can help. Of course, even the contemporary system, there is no curative treatment. But if the patient goes into a renal failure later on, CKD, or maybe the acute kidney injuries, then at that condition, they should not be blamed on diabetic system. That's why I take that precaution.
Okay, sir. Sir, Amvatari Rasa can be used with treatment
Yeah,
for
that, see,
unconditioned.
I don't comment on any of the yogas. Every yoga can be used provided you have a priority on the dosha lakshanas. I have given the prescription which I use in my practice. So, plenty of options are there. Hundreds of yogas are there. They can be used. Right?
Okay, sir. Sir, we request the delegates to unmute themselves and ask the questions if they still have some of the queries. If the delegates have any of the doubts, they can ask the question from sir directly by unmuting themselves. I think after this very elaborate class, all the doubts are cleared.
Okay, thank you.
Everybody is satisfied with the class and they have no doubts now.
Not
So,
nothing as well. Okay, fine.
yes, sir. So, thank you very much, sir, for this session. And we would like to hear more from you on more autoimmune disorders because there is a big list of autoimmune disorders which we want to clear up with your knowledge. We want to be perfect in those. So, would like to see you in future sessions too. And thank you from the whole team of Indian Institute of Ayurveda and Raj Shastra and the delegates. Thank you very much, sir. Over to you, Dr. Gopi Krishna, sir.
Thank you, Dr. Jyoti. Thank you, sir. Every word you speak is a sort of a mantra for us. Right from my medical schooling, it's almost like every word you spoke in our class is still documented with me.
Yes, and it's sir, three generations are studying.
Yeah,
Sir,
yeah,
our sir, your sir, and we. And our students are there. So four generations are here, sir, on
yeah.
one platform.
Yes.
Yes, sir.
So even we have doubt. The very first thing is I don't refer Samhitas. First I refer your notes. Then I have some doubts. Then I refer to the Samhitas because the things are so simplified. Just like the commentators have made the Samhitas more simplified, your class has made understanding the clinical implication of so many disorders so simplified. So thank you very much, sir. It is because of you we are here and we are like this. It's a blessing for us that we are your students.
Yes.
And definitely thank you very much for giving your lecture on autoimmune disorders in Indian Institute of Ayurveda and Rasa Shastra. As Dr. Jyote has already requested, we would always like to have more and more sessions from you so that we can get more knowledge about such concepts because it's a something like a lifetime achievement for us to hear to your classes.
Yes.
They are great experiences made in a ready plate. That's more easy. Or else it's very difficult for us to approach so many areas of gathering knowledge and analyzing them and implying in our patient and understanding it in the present way. So thank you, sir. Thank you very much for being with us.
Thank you, sir. Thank you, sir. Thank
Yeah.
you. Thank you, all the delegates. Thank you.
Thank you, all the delegates. And for the information of the delegate, we'll be meeting tomorrow